What up guys, it's Matt. Today I want to do a quick video about heated high flow nasal cannula. I kept it pretty simple. I focused most of my explanations on the flow and oxygen adjustments as well as some of the other parts that kind of make the whole thing work together. So let's get right into it.
Alright, so here in the first slide we see a picture of a heated high flow. This is kind of bare bones, it's not set up and ready for use. But the big things that I want to focus on are right up here. It's the oxygen blender and the flow meter for this high flow setup. These two things together as one idea, it kind of generate a lot of the questions that I get, particularly from nursing outside of the ICU for, what the heck is this? Why is it different? How is it charted? Why is it a better option for some of these COVID patients? And what's the difference between someone on a 15-liter oximizer or oxy mask or on a non-rebreather versus this? Going beyond just the flow, because a lot of their understanding comes from someone's on 10-15 liters oxygen. That's a lot of oxygen, and that's true. So this setup is very unique, so we're going to focus on these two, because these two components, the blender and the flow meter, are really what drive this as a totally next level modality to your kind of standard oxygen modalities. So here in this slide we have zoomed in on the flow meter, and as you can see, it goes from about 10 liters at the bottom all the way up to 70. So compare that to a normal flow meter, and you can see that those do about a half a liter all the way up to 15. So that's obviously a pretty dramatic difference. The reason that heated high flows are done through a heated and humidified circuit is because of the flows that we achieve. We often say anyone on more than 4 liters on a standard cannula here, we would do a little humidity or something, but those humidifiers typically cap out at about 6 liters, and then they start to swell up, and sometimes they'll start squeaking really bad. And then you can go to a different modality like an oxy mask, an oximizer, or non-rebreather, which we don't typically humidify those. Because of the flow, that's a limiting factor of that humidifier, but also like if you have a mustache cannula style oximizer, moisture will develop in that reservoir, and you can kind of waterboard your patients if you're not careful. Obviously, anything with a reservoir, typically speaking, you would never humidify. So obviously a non-rebreather is something you wouldn't do. So what the heck is the difference really between these two? And so the flows we're achieving, the real limiting factor as far as the oxygen the patient gets with a standard flow meter is the device itself. There are other factors, patient-specific, anatomy, how hard they're driving, how hard they pulling, all kinds of varying factors. But 15 liters really doesn't mean a whole lot, because when I turn on any standard flow meter, you have 100% oxygen coming out of the nozzle. So it's always the device that's going to really determine or limit the amount of FiO2 that's actually coming out of the device, versus this. When we're looking at this high flow meter, we are purely controlling the flow. And I mean that in its purest sense, is liters per minute, volume over a period of time. Whether it's on 10 liters or 70 liters has absolutely no bearing to the actual percentage of oxygen being delivered to the patient, and that is what really makes this setup unique. Going back to this first picture, so the other critical piece of this is going to be the blender here. So you can see coming out, you have a medical air connection and an oxygen air connection. Both are required here to basically manage anything from 21% room air all the way to 100%. And so this, combined with this flow meter, are what allows us to dial in and give patients exactly what they need, beyond the limiting factors of those other modalities. So I might have a patient who is real air hungry, but they're not necessarily in some sort of hypoxemic state. Maybe they're satting really well, but they're just working to breathe, and maybe you're trying to get them a chance to hopefully not to go on a BiPAP. Maybe you're trying to give them a chance not to get intubated. People can get short of breath without hypoxemia for any number of reasons. And this video is not really about that, but let's just say we had a situation like that. I can titrate. Let's say they were just wearing 2 or 3 liters on a nasal cannula, but they're breathing in the 40s. You could easily throw this on, set it to 30-40% FiO2 here on the blender, but you can give them 60 or 70 liters of flow, and that flow is what's going to help kind of like quell that shortness of breath, really help them. Now it's almost like a bit of a PEEP effect. They get that flow support when they take big deep breaths, and it's not pressure, it's not like BiPAP. It's just that flow kind of helping support those breaths. You augment a decent breath here, and you provide whatever oxygen they need to maintain. On the flip side, you might have someone who's very calm. Maybe they're just laying back in bed, but they're having a hard time staying in the 80s even. I mean, they're dipping to the 70s, or maybe they're trickling down to the low 80s, and you're really wanting them to hang out in at least the high 80s, with some of these patients. So, but they're not really working. You don't necessarily need to jet them with 70 liters of air. That might just make them uncomfortable. You can set this flow meter to 20 liters, but dial up the oxygen as necessary, 60, 70, 80, 90, 100%, to maintain saturations per order or protocol or whatever. So that's what's really, really cool and unique about this, and with some of these COVID patients, we've seen, especially with some of the ones we've had who are DNR, we were into a really unique situation. Okay, well, my facility doesn't do BiPAP on COVID positive patients because we don't have a way to filter our expiratory limbs, and we don't have enough negative pressure rooms to put everyone who needs BiPAP in one. So we will often max out one of these, so 70 liters, 100%, and then we still have the ability to throw like a non-rebreather on the back of it. And that's what's actually unique about that flow meter right here I showed you. We have these little T pieces built into a lot of ours too, so I can actually hook my high flow up to this adapter, and then I still have a standard flow meter, so I can flush this, or 15 or whatever, and hook a non-rebreather to the Christmas tree on that too, and really take advantage and give the patient everything they need when you're respecting their wishes not to be intubated. So that is what really makes this modality really unique. The last image I really wanted to focus on was the cannula. As you can tell, this is a lot wider than your standard nasal cannula. Obviously, it's capable of achieving flows significantly greater than that of a regular nasal cannula. Even a large bore cannula. In some high flow nasal cannula setups where they're larger bore and you run them through humidity and you can do up to 15. There's some special cannulas like that. This is, of course, far superior to that. This is actually a size small. The little cheek pads here are actually color coordinated, so orange is a small, there's small, medium, large, and there's a trach adaptable one as well. So this connects here to the circuit, so it's a standard heated limb. If you're familiar with heated circuits, either invasive or non-invasive, they're usually blue corrugated with a heated wire inside, and there's some temperature probes on the outside, and they run off the heater that you saw in that first image here off the side there. So And what's really, really important about the nasal cannula is that our goal is actually we want to achieve about no less than 50% occlusion of the nares with the cannula. So just because you got teeny tiny 90-year-old grandma, who weighs 80 pounds soaking wet, does not necessarily default her to having a small cannula. She may need medium, just like BiPAP masks. In my experience, it's 95% of your patient population, regardless of age, gender, whatever, require a medium. There are some cases where people, have really large nares, and it's not necessarily their nose. They may not have a big nose, but they can have just large nostrils. So it's really important to size those properly. You don't want to totally occlude the nose, but you don't want it too small either, because getting the proper sizing here is what achieves almost, we refer to it sometimes in the not so technical term of peepage. A little bit of that backflow, especially if the patient's exhaling through their nose against that pressure that they're receiving. They create that back pressure against all that flow, especially if they're on the 40, 50, 60 liters of flow, and it can create a little bit of a back pressure, which can kind of help with that oxygenation as well. Not the most scientific way to describe that, but that's the most lay way I can kind of describe that. So it's really important to properly size these. I usually wind up taking at least 2 sizes with me every time I'm going to set one of these up, and do a quick eyeball of their nares and see which size would be more appropriate. Even if that means opening up more than one, so be it, because I want to get the right thing on the right patient. So this little blue clip is just a little handy dandy clip we can hook around the circuit, and we can clip it to the sheet, the pillow, or the patient's gowns. That way the weight of the circuit and all this doesn't just hang down and pull on their face, to kind of help just keep them comfortable. So
Alright guys, so there's my video on heated high flow nasal cannula. I hoped it cleared up some questions you may have had, but of course, if you do still have any more questions or want any kind of further in-depth explanation, please feel free to comment down below. I'm always happy to help answer questions to the best of my ability. Guys, as always, thank you so much for watching, and I will talk to you guys soon.